Good afternoon, everyone, and welcome to the fourth day of the Australian Longitudinal Study on Women's Health Symposium for 2021, this year presented as a series of lunchtime seminars. We certainly hope that next year we might be there in person. I'm standing on the land of the Wonnarua people today and would like to pay my respects to elders past, present and emerging. My name's Deb Loxton and I'll be presenting with Senior Statistician Peta today on violence against women. We have one presentation today that will show you three different aspects of our research into violence against women. And after that, we're happy to take questions. Please put your questions in the Polev at any time, and we'll see you after the presentation. We're going to be talking about violence against women this afternoon, discussing findings from the Australian Longitudinal Study on Women's Health. Before we begin, we'd like to give you a trigger warning. If anything in the presentation upsets you, you can get in contact with Lifeline or with 1-800-RES-PECT 1-800-RESPECT, which is the domestic violence hotline in Australia. Please feel free to take a break or to leave the presentation at any time. No one will mind. My name's Deb Loxton. I'm the Deputy Director at the University of Newcastle of the Longitudinal Study, and I'm joined today by Ms. Peta.
Hello everyone. On behalf of Deb and myself, we would like to acknowledge the traditional custodians of the lands on which we meet today and pay our respects to elders past, present and emerging. We extend our acknowledgements to the people from the Wonnarua and Awabakal lands upon which Deb and I are coming from today.
During 2021, the National Plan to Reduce Violence Against Women and Their Children has been under consultation. We have submitted summaries of relevant longitudinal research and a summary of some modelling being led by Australian National University using longitudinal study data on the utility of offering income contingent loans to women who are escaping violence. We've also participated in workshops as part of this consultation, including one on health systems and one on research data development and measurements. The Queensland Government is currently developing a women's strategy, and information on women's experiences of violence collected by the longitudinal study has been submitted to that consultation as well. Today's presentation includes findings from three major bodies of work that have been underway during 2021. Firstly, we have reported on women's experiences of violence in midlife as a part of Major Report Q, which Annette Dobson reported on during Monday's presentation. We've also been conducting work funded by Australia's National Research Organisation for Women's Safety, which has been focused on the prevalence and impact of sexual violence in Australia. And lastly, during this year, we were commissioned by the National Mental Health Commission to have a look at women's experiences during the COVID-19 pandemic in 2020, using data that we collected as a part of the COVID surveys last year. As a part of that report, we had a look at women's experiences of safety during 2020, and we'll give you a brief overview of those findings as well. I'm now going to hand you over to Peta, who is going to talk about the quantitative findings for Major Report Q.
The next major report for the Department of Health is focused on various aspects of health and wellbeing for women during midlife, with one section of the report examining violence as a factor for health. For women who are aged 40 to 45 years in 2018, 50% had reported personal experience of violence in their lifetime so far. This was either as childhood abuse, domestic violence or sexual violence. For women aged 68 to 73 in 2019, 43% had reported experienced personal violence during their lifetime. If we look at these two cohorts of women at the same age, personal experience of violence was reported by 36% of women aged 45 in 1996, compared with 52% of women who were aged 45 in 2018. It is hard to determine the extent to which this difference reflects a true increase in violence prevalence or is influenced by growing awareness about violence over time, leading to reduced stigma and an increased willingness to report violence. On average, women who have experienced violence also experience poorer physical functioning, poorer mental health, and worse social functioning. They also tend to report higher levels of stress. This was consistently observed in both cohorts of women, those aged 45 in 1996, as well as for women aged 45 in 2018. Use of health services was higher for middle-aged women with a history of violence, which was consistent for women aged 45 in 1996 and again in 2018. Rates of health service use was higher amongst women aged 45 in 2018 compared to women of the same age in 1996. Data on child abuse was collected in a previous survey. For women born 1973 to 78, 29% of them reported child abuse when they were aged 37 to 42. Child abuse was reported by 26% of women born 1946 to 51 when they were aged 65 to 70. This slide shows a breakdown of types of childhood violence experienced by women. For the most part, there are minimal generational differences in the types of abuse experienced during childhood. The reported rate of psychological abuse during childhood was slightly higher for the younger women, those born 1973 to 78, while physical abuse during childhood was reported slightly more by the older women, those born 1946 to 51. Sexual abuse during childhood was similar for both cohorts of women, as was the rate of witnessing family violence during childhood. By the time of their most recent survey, domestic violence had been reported by 25% of women aged 40 to 45 years old and by 22% of women aged 68 to 73. This slide shows a percentage of women over time who have experienced domestic violence among those born in 1973 to 78 and born 1946 to 51. Domestic violence was reported by 14% of women who were aged 45 in 1996, compared with 27% of women who were aged 45 in 2018. Deb will now talk a little bit more about sexual violence.
Thank you, Peta. We'll now turn our attention to sexual violence and the data that we have within the longitudinal study. The lifetime prevalence of sexual violence was 51% among women aged 24 to 30, 34% among women aged 40 to 45, and 26% among women aged 68 to 73. In this case, sexual violence was any form of sexual violence that had been experienced either in childhood or adulthood. Sexual violence in childhood was measured by the Adverse Childhood Experiences Scale, which counts a number of different sexual abuse experiences that women had had. 12% of women born 1989 to 95, 15% of women born 1973 to 78, and 14% of women born 1946 to 51 reported experiencing sexual violence during childhood. While the prevalence of sexual violence in childhood was similar between the cohorts, there was a marked difference when it came to sexual violence perpetrated by a partner. A third of women born 1989 to 95 reported experiencing unwanted sexual activity by a partner, while 14% of women born 1973 to 78, then aged 40 to 45, reported unwanted sexual activity perpetrated by a partner. In part, this might be explained by differences in understanding of what unwanted sexual activity captures and what it means in terms of a partnered relationship. There are similar generational differences to consider when talking about sexual violence in adulthood, where the perpetrator can be a partner but may also be someone else. This type of sexual violence was more commonly reported by women who were in their 20s than it was by women who were born 1973 to 78 and 1946 to 51, then aged in their 40s and late 60s and early 70s. with 39% of women in their 20s reporting experiencing sexual violence during adulthood, compared to 18% and 12% of women in the other two cohorts. We've also examined sexual violence in relation to sexual identity. Among women in their 20s and their 40s, we found that women who identified as bisexual were the most likely to report sexual violence, with 76% of women aged 24 to 30 and 60% of women aged 40 to 45 reporting sexual violence. Women who identified as being exclusively or mainly lesbian were more likely than women who identified as being exclusively or mainly heterosexual to report sexual violence across all three cohorts. And I'll just note here that although we have data about bisexuality for women who are aged 68 to 73, the numbers were insufficient for analysis in this case. You can see the numbers there across all three cohorts reflect a similar pattern, with women who identify as bisexual being the most at risk of sexual violence. In the longitudinal study, disability and illness is assessed as being those cases where women require help with daily tasks due to a disability or illness. Across all three cohorts, you can see that women who report this type of disability or illness are much more likely than women without that disability or illness to report having experienced sexual violence, with 73% of women aged 24 to 30, 55% of women aged 40 to 45, and 34% of women aged 68 to 73 who have a disability or illness reporting sexual violence. Unlike findings for sexual identity and disability or illness, findings for area of residence showed little difference in prevalence of sexual violence for those women who were living in outer regional, remote or very remote areas compared with women living in inner regional areas or major cities, with a similar percentage of women reporting sexual violence across those three different areas. The longitudinal study has some of the most comprehensive data on violence and women's experiences of violence in the world. This permits us to have a look at the impact of sexual violence that occurred in childhood on other forms of violence that happen later in life. Compared to those women who had not experienced sexual violence during childhood, women born 1989 to 95 and 1973 to 78 who had experienced sexual violence during childhood were 50% more likely to report recent violence. They were twice as likely to report recent sexual violence, 33 to 59% more likely to report recent domestic violence, and 60% more likely to report recent physical violence. We've also been able to examine sexual violence as a predictor of socioeconomic status. On this slide, we're looking at the impact of sexual violence during childhood among women born 1989 to 95 and 1973 to 78. Women who had experienced sexual violence during childhood compared to those who had not were 46 to 63% more likely to have not completed Year 12. And they were 34% less likely to have obtained a qualification beyond Year 12. They were also 7% less likely to be in full-time paid employment in the 1989 to 95 cohort. Results were different, though, for those women born 1946 to 51 who were aged in their late 60s and early 70s when we captured these data. These women were 33% more likely to have obtained a qualification beyond Year 12 and 8% more likely to be in full-time employment. And this might indicate the presence of education as being a factor that assists women who've had these experiences, but something that doesn't show up until later in life. It's important for us to understand these factors in more detail. Although results for education were different between the two youngest cohorts and the older cohort, when we had a look at financial stress, We found that across all cohorts, women who had experienced any form of sexual violence were 30 to 45% more likely to report high financial stress than those who had not experienced sexual violence. We will continue to examine these data to get a better understanding and a deeper understanding of what happens to women once they experience sexual violence. I'm now going to hand you back to Peta, who will be discussing women's safety and the COVID-19 pandemic.
One of the COVID surveys completed by women in 2020 captured their experience of violence during the pandemic. Younger women were more likely to report interpersonal violence during the pandemic than older women. 12% of women aged 25 to 31, 10% of women aged 42 to 47, and 3% of women aged 69 to 74 reported interpersonal abuse or concerns about their safety during the pandemic. Women who had experienced prior personal violence were more likely to report high or very high psychological distress during the pandemic, with higher rates of psychological distress reported amongst the younger women. Among those aged 25 to 31, psychological distress was reported by 40% of the women who had previously experienced personal violence, compared with 23% of women with no prior history of violence. This disparity in psychological distress seen with prior history of violence was also observed among women who were aged 42 to 47 and aged 69 to 74, although the rates of psychological distress were lower for the older women.
In addition to the quantitative data collected during 2020, we also collected an extensive amount of qualitative data in the form of free text comments. The Mental Health Commission asked us to have a look at these with a view to estimating the impact of COVID-19 on women's safety during 2020. We found that experiences of stressful relationships, abuse and violence all impacted on women's feelings of safety. This included tensions in relationships and in general households outside of intimate relationships, and included relationship breakdown. Violence by a partner was reported and the ramifications of that discussed by women in the comments. There were also several cries for help that were included within the free text comments and dealt with by our usual procedures. I will note though that there were far more of these than we've ever dealt with before. Women also wrote about experiencing abuse, stigma and prejudice in public settings. In particular, they wrote about tensions in the workplace and infringements on their workers' rights and on their safety. Stigma, abuse and prejudice within the community were also reported, particularly by those working in health services, where women were viewed as being potential carriers of COVID-19. Housing instability and safety issues that occurred as a result of that and of financial impacts of COVID-19 were also reported. Insecure housing situations and the threat of homelessness impacted on women's feelings of safety and well-being, and there were further safety concerns in housing due to the actions of neighbours and also of housemates. All in all, the women's safety issues impacted negatively on women's mental health during 2020. These are some example quotes from women who were writing about their feelings of safety inside the home. This woman in her 20s wrote, "The level of conflict in the family has been ridiculous. My father drinks a lot, but COVID has increased that. Everyone is sick of everyone else." This woman in her 40s wrote, "My partner is very controlling. The increased time at home has led to greater control being placed on me and our children by him." Another woman in her 40s wrote, "Forced to delay separation by 7 months from husband who is coercive, controlling. I felt isolated and trapped at home when the pandemic hit due to the fact that he was in control of the finances and I had no ability to get an income or that even other people knew of the separation until he eventually moved out." And this woman in her 20s wrote, "Well, I have not had COVID-19. I'm still heavily affected by it. There's a very high chance I'll end up homeless next month because I can't find a new flatmate and my current lease ends next month and I can't afford the full rent on my own. It's left me with someone controlling everything I do and my money and has made me want to die several times." and these quotes are from women who were writing about safety outside the home. I, as a nurse, had to take time off due to being on immunotherapy. When I was at work, I was physically assaulted, which, although is always a risk as a nurse, I believe the stress that everyone was feeling during the beginning of COVID-19 was one of the causes of the assault. Another woman in her 20s wrote, "Working in retail as an essential worker, people are a lot meaner and take things out on you, and it really adds up, and it's a big mental struggle to not just keep breaking down all the time." In addition to the work that we've been doing with the COVID surveys, the work for ANROWS, and the work that we're doing for Major Report Q, we've also been working with Australian National University on modelling income contingent loans for women escaping violence. These options for financial assistance are similar to those used by HECS, and the people conducting the modelling are Janani William, Tim Higgins and Bruce Chapman, who did work on the original architecture for HECS. We've also been looking at the costs of domestic violence in collaboration with the Avon Longitudinal Study of Parents and Their Children in a collaborative project that will examine prevalence and costs of domestic violence over the life course, both here in Australia and in the UK. We're also using data collected by the Match study to investigate associations between childhood adversity with maternal and child outcomes. If you want to know anything further about the work we've presented today, you can ask us in a minute, or you can email either Peta or I on these email addresses. We'd like to thank the Department of Health for ongoing funding and the women who complete surveys on a regular basis. In addition to the core work for Major Report Q that we've presented today, the sexual violence work is supported by a grant from ANROWS. The COVID surveys were funded by the University of Newcastle and the Hunter Medical Research Institute, and the analyses today described about the COVID surveys were funded by the National Mental Health Commission, and we thank them for their funding as well. Hello everyone. We have 4 questions currently in the POLEV, and I'll take the first one, which was, why would being bisexual have a higher probability of experiencing sexual violence? And this is a really good question that I think needs quite a bit of work done on it in order to get a better understanding of what's going on there. Our findings were consistent with those of a UN report from 2018, and commentary on that report indicated that the media and pornography tend to display bisexual women as being objectified, and I think the quote was as objects for pleasure for straight men. And that is something that is worthy of more investigation. And I think there's definitely a place here for some qualitative research to ask women about these experiences and to get a better understanding of why those rates are so incredibly high among women who identify as being bisexual. The next question here is, does illness include mental health illnesses? And I'll ask Peta to answer that one.
Thanks, Deb. So when we were talking about illnesses, it was a disability and illness, and the question was phrased as, do you have a long-term or chronic disability or illness which impacts your ability and requires daily assistance with your everyday tasks? So it wasn't specific to a particular illness, and it certainly might include mental illness, but we don't have any further data on that. We could go back and check specifically what illnesses people have indicated, but we wouldn't know which illness it was that's requiring daily tasks as such.
Thanks, Peta. And the next question is, from a research perspective, what can be done to reduce the health impacts of violence aside from preventing violence? And that's a really good question. In most of our research that has examined the health impacts of violence, we've found social support of any sort to be very helpful with women's both mental health and physical functioning. Social support can be practical in nature. It can be people having someone to give them a lift to the doctor if they need it. It can be monetary, so people who have perhaps parents who can help them out with finances, but it can also be providing a shoulder to cry on, someone who will answer the phone if you need someone to talk to, and just that feeling of general support. I might go to the next question because it's related as well. How can the data be better used to understand women's safety? Well, one of the things that we can do is to unpack the different areas of social support to try and identify those formal and informal supports that are of best use to women in recovering from violence. But I think we also need to have a look at other factors that might be helping women to recover from violence. We do have a couple of current projects at the moment examining the impact of the Better Access Scheme on women's mental health in the context of violence. And with the team at ANU, we're having a look at use of health services, both hospital services and GP and Medicare covered services, to have a look at the impact of violence on use of those services. And we hope in the longer term to have a look at the impact of the use of those services on recovery from violence. I think we can also use the data to have a look at the places and the times in life when women might be most at risk of experiencing violence. And certainly because we have longitudinal data on violence, which is quite rare across the world. So really we're quite unique in that way. The capacity for having a look at violence in quite a number of different contexts is virtually unlimited. Peta, I don't know if you'd like to comment on that.
I think one of the other opportunities that the study presents is that we've got a level of trust with the participants, and we have done a smaller qualitative study a year or two ago, talking to some of the women about, how they responded to some of our questions. And I think there is an opportunity to do a bit more in-depth research with the women who have identified as having escaped violence, and finding out particularly in terms of their personal circumstances and what they felt helped them. That would be an extension of what we do in the survey. That I think that would require additional funding to specifically look at those issues and ask those women to help us out. But we know from our previous little sub-study that they're quite willing to help. We're very lucky with the women in our study. They're very obliging to help.
I think that's true. And I suppose one of the other things we have the capacity to do is to look at the cumulative impact of different types of abuse on women's health and wellbeing, and those things that have acted to prevent some of that health impact. And there's a group at University of Queensland at the moment attached to an ARC Centre of Excellence in family wellbeing across the life course who are having a look at that. Is there available data on which agencies, services, or what kind of help most women suffering from violence asked or used? I think, Peta, you presented a slide that showed really there's increased use across the board for all services, general practitioners, specialists, hospitals. Would you like to comment on that a little more?
Yeah, we can look through the MBS data and see what kind of services people have asked for. Also, the free text is another option as well, because we have learned just through some of our work with the qualitative data that women tend to give you further details in the free text comments. So I think that's probably one of the untapped areas for this, is to look at the free text and see what kind of information the women give about who they approach and how they go from it. But we can use some of the linked data that's definitely available for us as well.
Yeah, thank you, Peta. And I think mentioning the free text probably applies to a couple of these additional questions here. Does the data help identify how children of women experiencing long-term domestic violence can be helped? Not within the core data, but there is certainly the opportunity to have a look at the impact of the mother's experience of abuse on her children as part of the MATCH study, which is where we've recruited in the children of women in the 1973 to 78 cohort. We have data about those children and also their NAPLAN scores. And so I think there is capacity there to have a look at the impact, and plus to have a look at the differential impact across different families and different children. Another question here asks, does the data help us to understand perpetrators at all? And I have to say, not really. I am aware that the Australian Study on Male Health has collected some data on perpetration amongst males. So that would be one avenue to go and have a look at. There's some data there. And I think here too, the free text comments gives us some insight into how women perceive their experiences as occurring. And I know among the older cohort, that a lot of women have written about having made their bed and the need to lie in it, the impact of war on their partner's behaviour, other experiences that their partners have had that have led to post-traumatic stress disorder, which they believe leads to violence. So we can get a bit of a lens on the women's point of view on perpetration, but not on the perpetrators themselves. And then a reply: for children, reducing the length of exposure to violence can reduce effects, and supporting mothers to use positive parenting practices. Thank you, Katrina. And are women who participate offered additional support? How do you keep them safe? Well, that's an interesting question. And last year we did more of this intervention type work than we'd ever done before. So I will say COVID was a universal stressor that resulted in many cries for help through the surveys that we conducted, many more than we've ever dealt with in a 12-month period before. And some of those comments were to do with feeling unsafe. So we have a detailed protocol, which is ethically and legally approved by our various institutions, at what level we intervene and what we do. And I'll be happy to provide details of that, but it is a very long and complicated flowchart. So if the person who asked that question would like to email me, I'd be very happy to have a telephone discussion with you about how we do that. But yes, we do intervene under given circumstances as approved by our various committees and the rules that we conduct research by. Was there more information regarding women's demographics, such as ethnicity, for the sexual violence and other data? Peta, I might turn that one to you.
Yes, as with all our core data, we do collect quite a lot of demographic information. So we do have information on these women apart from just their, we do have ethnicity, what country they were born in, what's the language that they speak. We have quite a bit of demographic information. Once you start, particularly with some of the priority groups, so if you're looking at sexual orientation or, excuse me, disability, once you start cutting down into that finer layer within the cohorts, the numbers, we start to get into a smaller sample size for certain groups. So as Deb had alluded to earlier, for some groups, we'll just go, no, the sample's too small for us to be able to make a definitive statement about that. But yes, we do collect extensive demographic data for these as well.
I will also mention that this year and next year we are doing a cohort refresh specifically targeting those areas where we have fewer women in particular groups across the study due to migration. So after 25 years of conducting the study, there's been a lot of people who've moved to Australia and made it their home. And of course, because recruitment was in 1996, these groups are not represented in the study, and they'll be targeted throughout the cohort refresh process this year and next year. So we're looking forward to increasing those numbers. I don't have anything showing on my PolEv at the moment, but I also have a significant internet delay happening over there. Peta, do you have anything?
Not at this stage, not from what I can see. It's I'm looking at the different screens.
So I think we'll give people another minute or so. And I think one of the things that's interesting to note is where there are and where there are not differences by generation in the reporting of violence and what the reasons for those might be. It's been reported in other studies as well, where older women are less likely to report experiences of different types of violence. The one thing we noticed was that lack of a difference when talking about child abuse and particularly sexual violence in childhood, where there was no generational difference. Other people have said that this could be due to the severity of violence. So the more severe the violence, the more likely people are to report it. And that certainly would mesh with our data and our findings. There was a question here that asks, if we had to prioritise women's safety research, what component should we invest in specifically? From my point of view, our data has shown a lifetime impact on health and wellbeing of women who've lived with violence that lasts 16, 20, 25 years. I think because we have longitudinal data and we're talking about women who've already had the experience of violence, I would like very much to spend some time and invest in identifying specifically those things that help women to recover from experiences of violence. Obviously, primary prevention, stopping violence happening in the first place, is a great place to invest money. But I think there is a need to have a look at how we can provide services, or what services we provide that can help women to recover, or have the best chance of helping women to recover from these experiences. And when you think about the high percentage of women who've had these experiences, it's really a good proportion of the population there who are experiencing a health deficit due to the experiences they've had of violence. Peta, did you want to add anything to that?
I think I agree with you. I think it's a lifetime impact. I also think it's not just women. I think we've seen with our results that there's a significant proportion that are reporting consistently across cohorts child abuse, and I think that the support that's needed there that continues through adulthood. It's not just pick a date, you know, in their 40s. So I think it's something that we have to address across the life course.
Yeah, I agree. And a question here that asks, does the survey collect on use of specialist family and domestic violence services or other services that are outside of the health sector? We collect some information on use of other services, but not family and domestic violence services specifically, is the answer to that. Certainly something we could have a look at. Those services are very diverse, so it does become a little complicated, but it is something we could investigate further. Peta, did you want to comment on that?
No, I agree. It's not on specialist family and domestic violence. We do ask women, and it hasn't been at all surveys in terms of counselling services, support services, just individual things like that. But hasn't been a consistent measure for those ones across all services, all surveys for all women.
Excellent. And I can't see any more questions in the Polev. And so we'll thank you all for your attention today, and thank you, Peta, for co-presenting. And thank, as always, the women for providing the data on these very complex issues. Thank you, everyone.